This is Dr. Mary Chamberlain, and I'm here with Dr. John Ward at the Centers for Disease Control and Prevention in Atlanta, Georgia. Today is Tuesday, September 26, 2017. I'm interviewing Dr. Ward as part of the Oral History Project, The Early Years of AIDS, CDC's Response to an Historic Epidemic. John, welcome to the project.
Thank you.
Do I have your permission to interview you and to record this interview?
Yes, you do.
John, you first arrived at CDC as an EIS, or Epidemic Intelligence Service Officer, assigned to the AIDS program in July of 1984. Much of your early work in the AIDS program focused on the risk of HIV transmission by blood transfusion. You subsequently assumed a series of increasing leadership positions within the AIDS program. Later, you became the editor of the MMWR in 1998. And since 2005, you have served as the director of the Division of Viral Hepatitis. But before we discuss your work on AIDS at CDC, let's talk a little bit about your background. Could you tell us where you grew up and about your early family life?
Sure. I was born in Montgomery, Alabama. I spent most of my childhood there. My father was a computer analyst for the U.S. Air Force at the Air Force Base there. And my mother was a clerical worker at a local department store. I had one older sister who went on to become a social worker and head of foster care programs for the state of Alabama. And I think it sort of reflects the family I grew up in. I think there was a very religious-oriented family, one that was very involved in large degrees with various social programs. And I think it sort of helped shape some of my attitudes in medicine later on. I got interested in medicine because of a high school teacher in physiology who was very captivating and suggested that I had the right aptitude, I guess, to go into medicine, and so that got me thinking about that. And I went to the University of Alabama in Tuscaloosa as an undergraduate in biology and with a minor in history, and then applied and got accepted to the University of Alabama School of Medicine in Birmingham, which is where I did my medical undergraduate training.
And then did you stay in Alabama for your clinical years?
I did. I did my internship and my residency at Alabama. And indeed, when I came over to interview for the EIS program, the interviewers asked me if I had ever left the state. It looked like I'd been fairly cloistered all my life. So I've always felt like I was on the remedial program here at CDC with that kind of introduction to the agency. But we had a very good infectious disease program there, and actually Jefferson County, which is where Birmingham is located, was one of the 4 counties that had a viral hepatitis surveillance program supported by CDC. And I got very interested in public health as a freshman in medical school because a Methodist minister who ran the student union at the University of Alabama has started a program called the Alabama Coalition for Community Health. And he would sponsor, or he would get the communities to sponsor health fairs around the state. And then medical students would go and staff the health fairs and do screenings of various types, which was beneficial, obviously, for marginalized populations in the state, but it also helped those communities understand how they could work together to solve common problems. And there's examples of communities continuing on to apply for federal grants for water purification plants, et cetera, et cetera. And so we went and actually lived with the Creek Indians for weeks at a time. We lived with the Choctaw Indians for a while because they had to be responsible for putting us up, finding a place for the health fair, finding a place for everybody to live, et cetera. And it really it was very energizing to meet these populations. Even though I had grown up in Alabama all my life, I really was not aware of those populations until working, in that program. So when I became a resident, I asked to be assigned to the health department.
As one of your rotations?
As one of my
elective
electives.
rotations?
And I was actually the first internal medicine resident to ever
I bet.
to ever have a elective at the local health department. And so when I went over there, I worked in the TB clinic. But then I began just to look at the hepatitis surveillance data and got and then I became interested in vaccination because the Hep B vaccine had just become licensed for use, and I became very interested in how it was being used among the house staff. So that was really sort of my first very elementary introduction, to epidemiology and public health was there.
It strikes me that and you said this in your comment, that you were the first student to go over to do, or resident to go over and do an elective in the public health department, because these were the days when public health was not on any medical student's top 10 list of internship residency programs. I mean, it was kind of the bottom of the barrel that, in terms of from the medical student's perspective of people that ended up in public health. So you were really ahead of your time, so to speak.
Yeah, and even our epidemiology course in medical school was voted the worst course that
Yes.
we had. In fact, but despite that, I think in part because of that experience in those summer programs, I became very interested in public health. I also began to realize in internal medicine in particular how many diseases you're being asked to be responsible for and take care of are preventable, and much better to be prevented than to be treated.
Mm-hmm.
And I think that was the other impetus for me to get interested in public health. When I was working at the health department in Jefferson County, the local county epidemiologist, Jim Alexander, brought me over. This would be about 1982. Brought me over to a meeting of TB, of a TB program coordinator meeting. So that was really my first meeting at CDC with Dixie Snyder, who was then head of the tuberculosis program, chairing the meeting. So that was my first introduction to CDC. I then went back into my residency, and I had gotten interested in international health as well. I had done my last 6 months of my final year in medical school. I had had an elective in Melbourne, Australia, studying pediatric immunology. So I got very interested in more global travel, more global experiences. So I somehow arranged an elective at the London School of Tropical Medicine and Hygiene, and thanks to the good graces of UAB, they allowed me to serve that elective. And I really can't remember how I put that together in the days before Google and email, et cetera. But I went over, spent 2 months doing clinical ward work and attending lectures, et cetera, which only increased my interest in global health and really into some aspects of public health, I guess. So I got very interested in visiting the World Health Organization. And so I had the head of the program at the London School, the clinical program, write me a letter of introduction. I took, there was no channel at that time, so I took the hovercraft over, got seasick on the way, hovercraft to Calais, rented a car, drove to Geneva, Switzerland, to interview. And so I got an interview set up with the World Health Organization, and Mr. Fontaine interviewed me. I can still remember his name, and he started interviewing me in French. And of course, I know a little French, but not enough to conduct an interview. So he completes the interview and says, "You're way too inexperienced to work for WHO." And I said, "Well, where can I go get this experience?" And he said, "Go work at CDC."
Ah, so that's how
So,
you heard
so
that.
that was really my first eureka moment, like, hey, maybe I should go work at CDC.
Gosh, and it took traveling to London and by air, then by boat, and then by car
Yeah.
to finally hear about CDC.
Yeah, exactly. I had to go hundreds of miles. Yeah, exactly. It was really funny. And then it's like learning a new word. So then I come back to my residency, and lo and behold, the head of our residency program, Dr. Bill Dismukes, was a former EIS officer, infectious disease physician at UAB. And so I began to talk to him. And then I found that a resident a year ahead of me in the program was already applying. That would have been Ed Kilborn.
Oh, okay.
And so I began to talk to him about CDC. And so he got accepted a year ahead of me and went off and did, I think, environmental health or what his area of interest was. And then Dr. Dismukes helped me with my application. I think was very supportive. Called CDC to reinforce his recommendation for me, which I greatly appreciate him doing.
Now, when you were in between all of the travel, you obviously were seeing patients as part of your clinical rotations. Had you seen any AIDS patients either in Alabama or even in London at that time? Because it's the early 80s and they were starting to pop up.
Right. Did not see them in London, but when I came back to Birmingham, I was very interested in infectious diseases already, and I was doing my infectious disease rotations as part of my internal medicine residency program. And we would have rounds most mornings with the attendings where cases were presented. Now, at UAB, the infectious disease program was one of the most highly regarded departments at UAB, and the physicians there who were the professors in that department were considered, some of the best doctors there. So, we felt like they were masters, of the universe, as we used to say. And so they began to describe this man in his 30s or 40s from Huntsville, Alabama, several hundred miles away, that had this respiratory infection, and he had hemophilia, and so we began to go through. The head of the department, Dr. Glenn Cobbs, began to go through the differential diagnosis, and then we kept waiting for him to tell us what this person had. And he goes, I don't know what he has. And I can still remember the chill going up my spine, that the fact that this really previously young man, granted with a chronic blood condition, but previously good health, would come down with this life-threatening pneumonia that he eventually died of. That was, at some point we found was pneumocystis carinii pneumonia. And that was about 1983, I think. And he actually, that case was one of the first cases that was in the compilation of cases that CDC reported that included persons with hemophilia.
Okay.
So that was my first introduction to HIV/AIDS, was that person with hemophilia in Birmingham.
So was it at the end of your 3 years of internal medicine residency that you had sent in your application to become an EIS officer at CDC?
That's right.
Okay. And you and your EIS classmate, believe it was Tom Peterman, you were only the second set of EIS officers that had actually ever been accepted into the AIDS program at headquarters in Atlanta. When you came to interview for EIS during the conference and the matching process, had you set your sights on the AIDS program, or were you, with all of your travels and experience, you certainly had a lot of interest. What did you come to Atlanta looking for, and you obviously ended up with AIDS, and I'm just curious about how that worked.
Yeah, it was interesting. I had gotten interested in hepatitis, as I mentioned, because of my exposure to the health department there and their data regarding hepatitis and hepatitis B vaccination. So I really came over most interested in joining the hepatitis program.
Okay.
But when I got here, I found that the hepatitis program only was assigned an EIS officer every other year, and I was here in the off year, so they didn't have a position for hepatitis. Now, at that time, the interviews were conducted on a Saturday and a Sunday, and then for EIS. And as you know, Mary, it's very much like fraternity or sorority rush, where you're trying to find who you think would be good, and they're going to give you a ranking as to who they want. But on the Friday night beforehand, the people who have positions in the EIS program in their departments, they were given 3 minutes to describe their positions, to attract you to
pitch, right?
To give their pitch, exactly. And I can remember Jim Curran, getting up, and I'm sure he said a number of things, but the one thing that really stuck with me was that he said how this whole epidemic was unfolding. There's a lot of unanswered questions, and he who knows AIDS will know medicine. And it was like I had, just
that was his hook.
That was my hook, and it hooked me big time. I mean, it was like the V8 moment, the light bulb going off. It's going like, of course, this is just epidemic is just beginning to start. I really want to be a part of this. Now, this is on Friday night, and as you know, Mary, during that whole week of the EIS conference, people are having breakfasts and lunches and gatherings to attract interest. And I had not gone to any of those for the AIDS program because I was thinking I was going to be interested in hepatitis. So I had a lot of catching up to do. So I did my interviews with Jim and with Harold and with Ken Castro, who was the EIS officer in the year before me, and then cycle back around on Sunday to let them really know my interest in this. I think it might have helped that Jim Curran's wife was from Alabama. I'm thinking that there might be a little connection there. He maybe gave me a nod, but I felt very appreciative when I got the call that I had matched. So I was really excited about that. So that happens in March or April.
April, right?
April. Yeah. So, and then you still have several months to go back and finish up your residency program. So I go back to do that, and about a week or so after getting selected to be part of the AIDS program at CDC, Bob Gallo and Luc Montagnier published their papers saying they have discovered the virus that causes AIDS, which at that time was known as HTLV3 and the lymphadenopathy-associated virus, LAV. And I can remember all of my colleagues in my residency program going like, well, that's over, John. I don't know why you joined that program. They're going to find a vaccine for that, So there was a little bit of a miscall there. So that was my...
yeah, we're still looking for that vaccine, aren't we?
We are still looking for that vaccine.
So your arrival in Atlanta, which would have been in July of that year, it's really at a pivotal time. The cause of AIDS has been discovered, and there are now serological tests to detect the virus that became commercially available in March of '85. And the availability of testing was obviously a watershed moment, and in particular for blood banks, because at that point in time, national surveillance was showing that about 1-2% of all AIDS cases reported to CDC were associated with receipt of transfusions. And although the Public Health Service, as early of March of '83, had recommended that people who are at increased risk for acquiring this new disease, this new infection, should refrain from donating blood and plasma, we all know that that's far from a fail-safe prevention measure. So all of this is unfolding. You begin the summer of 1985 in Atlanta, summer of 1984 in Atlanta. And I'm curious, because much of your EIS work and after it is associated with working on blood transfusion issues. How did that come about? Did you volunteer for this? Were you volunteered? Had you started on another AIDS-related project and then diverted over to this. So I'm just kind of curious how they got you slotted in this particular area.
No, when I arrived, they basically said, John, your job is to protect the nation's blood supply.
Protecting the nation's blood supply.
Of course, I was going to have help, but that was pretty much that's pretty much what I was assigned to right at the moment. And as you alluded to, this was a very contentious aspect of the AIDS epidemic because it was a risk that potentially anybody could have receiving blood that was contaminated with HIV. There was there was this sense of the innocent bystander of the AIDS epidemic, of people, without anything that they could control becoming infected. So it was a very highly visible part of the AIDS epidemic that attracted a lot of interest from a lot of different sectors of society. And obviously, it's a very major focus of public health to protect the blood supply. And we did a lot of work with the FDA in that regard as things moved along.
Now, I'm curious because in your comments from the last few minutes when you walked us through your training and your various travels, I didn't hear any mention of blood banking.
Exactly.
So this was, I presume, a whole new arena for you other than maybe ordering blood transfusions as a resident. How did you get up to speed on just what the basics of blood banking are and who the players are?
Yeah. And I really think that was one of the real beauties of epidemiology and real beauties of working at CDC is that at CDC, epidemiology is perceived to be a mobile skill, and you're to move around and apply it, as needed. And I think that's what I've seen time and time again here at CDC. And in my case, you're expected to come up to speed on through reading about blood banking and begin to develop relationships in the field. So we began to work on a regular basis with the American Red Cross, American Association of Blood Banks, and the individual Red Crosses around the country at that time. And so you really began you go to their meetings, you attend their conferences, and then progressively you become more and more knowledgeable about that field. And I think that's actually one of the real attractions of epidemiology and working at CDC is that you can move around and while still having the basic tenets of public health and epidemiology in mind, you can apply that to a variety of different health issues over the course of your career, which makes it a much more rewarding career as a result.
Preparing for this interview, I went back to read some of the relevant publications and CDC's MMWR, and it was interesting. In January of '85, the Public Health Service came out with recommendations anticipating the availability of now commercially available HIV testing, a serological test. And these recommendations were introduced with some fairly cautionary language. They said while there's considerable experience with using the ELISA test, which was a serological test in research laboratories, much additional information will need to be gathered following its widespread application to screen blood and plasma donations. So although the test was obviously welcome, it was clear that there was a lot to be learned about unleashing it, if you will, on a population of blood donors who would normally be expected not to be having a high prevalence of infection. Can you talk, I want to talk obviously a lot about the study that you and others went about in evaluating this new test in the real world setting of the blood bank. But maybe before we get to the mechanics of it, can you tell us a little bit about what were some of the concerns or pressing questions that screening millions of donors of blood and plasma were being raised? What were some of the concerns and the questions that your studies really needed to address?
Well, that's right. I mean, just how well would the test work when screening millions of people every year rather than being out of the research environment? what kind of quality control issues within individual laboratories, the sort of the variations just by the different staff working on the test in laboratories. Who was being found positive?
Right.
Were they really infected? Blood banks were always worried about throwing out blood unnecessarily, and so are you over calling an infection and therefore having a valuable product, discarded unnecessarily? So those were big issues too. And then, then actually, how well does it really work in protecting the blood supply? So so there was sort of a mix of concern about quality, concern about documenting that the test was indeed good, so you could protect the blood supply, but also reassure the public that the blood supply was being protected by the blood screening, and then minimizing the discard of blood unnecessarily.
Right, and that discard of blood, obviously, if the unit tested positive, no matter how good a test is, if you're using it in a presumably low prevalence population, you're going to pop up with some false positives. And obviously, even if subsequent testing went on to show that it was likely that the donor was not infected, the blood bank would be nonetheless obliged to discard the unit. Were people concerned, again, about the impact this might have on the donors themselves? Because I know the blood banks are very, back then and still today, are very protective of their donors in the sense that they're very appreciative, obviously, to these people who've given a lot of their time, and many of them do it repeatedly, to donate a unit of blood or plasma. But were there also real concerns about the potential social or psychological impacts that it might have on donors to sort of be calling them up and saying, well, got the results of your test, it's positive? I was curious if that was also part of the mix of discussions that you had before undertaking the studies.
Not before undertaking the studies. I mean, there was some concern about how you convey the information to donors as they became infected. I would have to say that the largest issue around donors was that by having the testing available in blood banks, the major concern was that you would be attracting people who were at risk, had no other way of being tested, and then would go and donate blood just to see if they were infected. And even if the test was good, you're going to miss some people because no test is perfect, and so you would actually be causing some harms unnecessarily. So the other sort of complementary activity underway was to provide some alternative test sites around the country so that those people who did want to know their status would have an outlet rather than a blood bank. So it's a secondary way of protecting the blood supply.
Yeah, that's a really good point, and I'm assuming that you really weren't particularly involved in the setting up of these, quote, alternative test sites, but that was fairly novel, I think, in and of itself, that this new test is available. There's a sense that people will want to know what their status is, and there was really no place to go. I mean, you couldn't go to your doctor's office for the most part and ask for a test, so people were going to show up at blood banks, which I could see would be worrisome. So
right, and for some, they may even feel like it's more confidential than going to their
good point.
Going to their small town physician or something like that. And,
okay.
So there was a big concern about the donor population changing because of the attraction of that test being available.
Okay. So I imagine these were all...
It was all swirling about.
It was swirling. Who were some of the players that were engaged in all of these discussions? And
well, there was a lot of...
obviously people within
obviously
CDC.
within CDC, I would brief Jim Curran, obviously, Harold Jaffe. Jim Allen was my immediate supervisor, responsible for these and other epidemiologic studies. Walt Dowdle, who was
Okay.
deputy director of the CDC at that point in time, and Jim Mason. I mean, this was a high
The director,
visibility,
yeah.
issue within CDC. And then we would meet with people with FDA on a regular basis. The heads of blood banks, Roger Dodd comes to mind, and at the American Red Cross. Paul Holland, who used to work at NIH in the transfusion service, who was ran the blood bank in Sacramento, was still very influential. Harvey Alter at NIH was very involved in those early days. There was a number of I can't. Probably you don't have to use this, but I mean, I can't really recall all the various community advocates at that point that was having to say around around testing, but just access to testing
Was a big
because
issue.
it was getting licensed. Now, how do you make this test available?
Right.
Was gathering steam as a major point of discussion between community advocates and the government, which still continues to this day.
So let's talk a little bit about your first big study to protect the nation's blood supply, as Jim Curran had charged you when you walked in the door as an EIS officer. How was it decided that CDC would join forces with the American Red Cross and their regional office here in Atlanta to do a collaborative study on the test, how good it performed? How did that all come about?
Wasn't privy to all those conversations.
Oh, so some of them antedated
EIS.
your arrival, or?
Well, I think the test came out in, as I recall, in February. It was licensed in February of '85. Within just right around that time, or maybe within 1 or 2 weeks, Jim Curran and Harold Jaffe come to me and said, we're going to do an EpiAid to investigate how well this test works. And I think it reflects the ongoing collaboration CDC had with FDA already. You mentioned the 1983 meeting. CDC was already very involved in this whole area of HIV. We can do this type of study much better than FDA can, I believe. So we took it on, and they said we're going to do it here in Atlanta with the Atlanta Red Cross. And so we went over and met with Al Grindon, who was the chief medical officer of the Atlanta Red Cross, and I'm not really sure how all the funding worked at that time.
Probably better not to know.
Exactly. But it was an emergency situation, and things get done. So we fashioned a study. We developed sample size calculations. We developed from the package insert, the estimated sensitivity and specificity of the test. We estimated a prevalence, and then we estimated how large the study needed to be meaningful. As a young EIS officer, I think it really taught me how to evaluate a test. Predictive value positive, predictive value negative, and a lot of people talk about sensitivity and specificity when they talk about tests, but what they're really talking about is predictive value positive and predictive value negative, because it varies. Your test interpretation varies depending on the prevalence of the infection in the population that you're testing. In the case of blood donors, you're testing a fairly low-risk population. My job, after writing up with help, the protocol, basically, I went out and interviewed people who were positive on the test. And I did that in 3 places. I did that at the Atlanta Red Cross headquarters on Monroe Drive. I did it at CDC. CDC had a little clinic at that time right between Building 1 and Building 6, which are no longer existing. And people would come in, and I would see them there and talk to them. I had a standard interview, of course, draw blood on them, and myself, and then have that tested at CDC for confirmation and of the antibody result, and to do the Western blot to confirm the presence of HIV.
Were people cooperative? Did you get, because obviously the test, the Red Cross would be running the serologic screening test and then identifying who people were that were deemed to be positive. I believe CDC's labs were doing the confirmatory testing for them. And then would offer, I guess, to these positive donors the opportunity to enroll in the study to be interviewed by you.
That's right.
Were these positive donors cooperative?
They struck me as very cooperative.
Yeah, because you were trying to find out if they had risk information.
Yeah. I had very few refusals. And you know, again, we have to remind ourselves that this study was being done in 1985 in Atlanta, Georgia. The AIDS epidemic is only about 4 years old. You know, most people don't know they're infected.
Right.
And so there were some remarkable, there were remarkable personal stories, that were sort of uncovered by the testing. Now, obviously, I met a lot of people who were false positive. You know, they were not infected with hepatitis C. They were not infected with HIV. And they had fairly, histories that that was fully consistent with that test result. But then you also were telling people for the very first time that they were infected with a virus that causes AIDS. And
oh gosh, so
I really was the first one to tell a fair number of people that they had, the AIDS virus in 1985 at a time when, it was a very, very scary disease, and still should be currently, but unfortunately we have a lot of interventions that make it less scary than it was at that point in time. And the stories really vary, and I as a case of a few come to mind. One, a minister in a small southern town, married, 3 to 4 children, would come up to Atlanta to see his parishioners in the hospital, but then stay over and have a separate lifestyle that he was associated with in the small town, and so he was had to tell him he was positive. He had to share that information with his family, and he became fully open about his sexuality, and began to live his sexuality. Moved to Atlanta, and fortunately, he was a long-term survivor, and I saw him about at least 12 years after my study, and he was still doing fine, and heavily involved in various AIDS causes, and so that was one example. On a more tragic note, I interviewed a woman who was found to be positive, who had only had she, after years of celibacy, had just decided to become more sexually active. Had only 2 sex partners, and unfortunately one of them was HIV infected, and she had become infected just recently. On another one, I interviewed a man who was living in Atlanta from the New York City area, and he reported that he had 50 or more female partners a year and had no other risk for HIV, and so I attributed his risk to heterosexual transmission. Years later, when I was working at the VA hospital here in Atlanta, doing my clinical rotation as part of my Commission Corps activities, that individual came through
Oh, my goodness.
as a patient
Oh, my.
and admitted that he had made the whole thing up and that he was actually an injection drug user.
So did you two immediately recognize each
Oh,
other?
yeah. He recognized me and then introduced himself, and then
Oh,
we
my
began
goodness.
talking. And so so we had to, correct that on the form, but because heterosexual transmission, is a little bit less
Yeah.
common, particularly female
Right,
to
in those
male.
early days.
So it was a little bit more consistent for him being a drug user. And I met gay men who were already more open than the some other than the one I just described, who really began to I had to return for some follow-up confirmatory testing, et cetera, and so we sort of developed a little bit of a relationship at a time when there were the number of physicians who actually knew anything about HIV was still fairly small at that time.
Yeah, and I'm really also struck how difficult this was, because at this time, as you say, there's not a lot of physicians that know much about AIDS. We were still learning about the natural history of AIDS. You couldn't really give them a lot of detailed information about the likely course of their disease. There was no treatment that you could really offer them. There were certain preventive messages that you could deliver, which, as you illustrated, in some instances would involve then having to share their status with sexual partners or others. So this, I can see where this just must have been a really wrenching part of the study for you.
No, it really made it real, very real what was happening. Having it done at the personal level, and so we did that study from late February through May. I presented it at the EIS conference.
And what did you find? I mean, so in terms of the performance of the test, I mean, I'm sure everybody was interested in how that was turning out.
I will. We were really trying to keep the study a little bit under wraps, so again, not to influence who was coming in to get tested, et cetera. So in addition to testing people here at CDC and at the headquarters of the American Red Cross in Atlanta, sometimes I would go out into the more rural areas and go to some of the smaller offices of the American Red Cross. And I remember going down to LaGrange, Georgia, which is about 60 miles south of Atlanta. And I was supposed to meet a donor who was positive there, and the Red Cross office was on the second floor of the courthouse. And so I sat on the steps of the courthouse waiting for this donor to come by. And Coca-Cola had just changed their formula from sugar to corn syrup. And so this media truck pulls up, the local radio station pulls up, and the people get out with all these microphones and everything. I'm going like, oh no, someone's found out about this study. I'm going to get interviewed. I'm going to get interviewed here. And sure enough, they walk right up to me and they go like, can we talk to you? And I go like, oh, yeah, I guess. And they go like, what do you like better, New Coke or old Coke? So I think I like old Coke better. So that was so that was a little overcall on my part. So anyway, so we did. So again, it was good to get sort of the full experience there. So I brought the data together. My first study at CDC, very simple study, which was perfect for me, and I began to analyze who was positive and then who was positive on the Western blot to show that they were truly infected with hepatitis.
The confirmatory test.
Surely they were fully, really infected with HIV. And I found that the persons who had a small number indicating less reactivity on the antibody test
Okay.
were least likely to be positive on Western blot,
Okay.
and those that had a very high value were most likely. And so I came up with anything over 6.0, you had about an 88% chance of being positive, whereas if you were less than 2, it was 6% or 10% chance of being truly infected with HIV. And I have to say, being my first introduction into doing studies, I marveled at the fact that for that little space of time, I was the only person in the universe that knew how well that test worked, in the blood bank setting. And so then I went in to show the results to Jim Curran and laid it all out for him. And of course, I'm, not fully certain about how to interpret these findings, and I said, people that were positive with a value of 6.0
So
or
strongly
higher,
reactive to the
if they were
serologic.
strongly reactive on the antibody, they had an 88% likelihood of being infected with HIV. And I said, it's not 100%, but it's 88%. And so Jim goes, it's okay. It makes it more believable if it's not 100%. So that was a good joke. We had a good laugh about that. But, then we presented it. We rushed it into publication. It was published in JAMA. And that 6.0 was really used as a real, those kinds of values for a short time as people began to get familiar with the test, was really used to help interpretation in laboratories, around the country.
So your findings did lead to, I don't know if modifications is the right word, but it helped people interpreting, if you will, the EIAs and setting maybe some cutoff values and whatever?
Yeah, absolutely. And then also just the likelihood of helping with the interpretation
Of the test.
with the EIA, and helping as a result, like if you got a negative Western blot, but you had a high value on the antibody test, it was indicative that you probably should redo the Western blot, that maybe the Western blot wasn't
okay.
done well.
Okay.
So it really helped in the laboratory interpret the test as people began to get more and more experience with it.
Okay. Yeah, so this real-world, real-time evaluation of a test that is still with us today, obviously much improved over time, but was the CDC Atlanta Region Red Cross study the only study that was happening to evaluate the test? Were other entities involved? I was just curious if everybody was zeroing in on this very detailed study here in Atlanta, or were there others, and if you were communicating or collaborating or sharing results, and just curious.
No, it was really the only one.
Really?
Really at that time. I mean, it was really, we were still a fairly small operation
Yeah.
then, and AIDS had not really caught on as a large national health issue, even though there was a lot of concern about the blood supply, and the case counts were up to around 5,000. We still did not have large budgets to study AIDS or to seek to prevent AIDS. I think that really began to change when Rock Hudson was diagnosed with AIDS, and people really began to take it more seriously. When I first got there to the AIDS program, the Georgia Public Health Association invited us to give a talk on Jekyll Island about AIDS, and I was asked to go, and of course I said yes, but we did not have enough money in our travel budget to travel
For
somewhere
you to drive down to Jekyll
from
Island.
Atlanta, Georgia to Jekyll Island on the Atlantic coast. It was really amazing. And, over several weeks, we were able to, muster the money. And I did end up going, but that just sort of shows you how thin the margins were as far as budgets were.
So this new
concerned.
test it was being deployed in other, certainly, blood centers around the
absolutely.
country. But I'm really fascinated to learn that there was just this one very detailed look going on at the Atlanta region, this collaboration between CDC and the Atlanta region of the Red Cross. That's fascinating for a test that was going to have that much of an impact.
Yeah. I really have to say, I've often thought that the CDC in the early days of the AIDS epidemic was very much like the Washington Post in the early days of Watergate. When we were pretty much the only game in town for investigation. And then over time, more and more people got interested in it, got involved in it, and so information became coming from different sources. But that at that time, CDC was in the lead, and I think all of the people you interview for this history will agree that one of the accomplishments that CDC can be the most proud of is the steps we took to protect the nation's blood supply.
Do you remember, as a result of the study became public, you alluded to there was an MMWR, there was your JAMA publication, but I believe the results probably became public more earlier than the JAMA publication. Do you remember what the reaction was among public health officials, the blood banking community, the general public? Because we talked earlier about the concerns, the deep concerns going into the study about how well would the test perform? Were we going to be in a position of having to discard a large number of units? Do you remember what people's reactions were or how that played out more
Well, it was
publicly?
very well received because it was very good news that the people that were positive, for the most part, were truly infected, that the number of persons being found to be positive was relatively small, and so the test was functioning, very, very well. So it was a very welcome news. If anything, we had to harness the enthusiasm of the blood banking community because they wanted to really be very robust in their estimations of how many infections were being prevented here and the number of infections that were being missed. And we didn't feel like we had enough information to yet say that. And so it was a little bit of, I guess what we would call now irrational exuberance among the blood banking because the test was performing so well.
Well, on that note, as the saying goes, no test is perfect. And sure enough, it wasn't long before cases of AIDS started to be picked up in persons who had purportedly received blood that had been screened by this new test and found negative for HIV antibody. And you and others published a detailed analysis of 13 HIV-infected persons who had received blood from 7 donors in February of 1988 in the New England Journal of Medicine. So let's talk a little bit about this. So first of all, you start hearing about these cases. I'm curious how these cases started to come to light. And were you shocked? Was this unexpected?
It was surprising. It was really like, you're really there dealing with the unknown, so you really don't know quite what to expect. Again, it's a real testament to how clinicians have a vital role in public health surveillance because they're the ones who began to call attention to these cases of people having HIV antibody detected that had no risk other than recently receiving blood transfusions that had been screened by blood banks, and we had just shown that the testing was good. So what we did was we went in, I interviewed the clinicians, got the risk information of their patients, and then we got the information about the donors to those cases. And they were happening around the country.
Okay.
These weren't, to your point, there weren't large numbers of cases at that time, but they could be indicative of a larger problem because not everyone obviously is getting tested after they get a unit of blood. What we found was that the donors had evidence of recent exposures that could have infected them with HIV, and that they were in what was called the window period between the point of infection and the point of developing detectable antibody. And so that really helped to identify an area for quality improvement of the test. How do you shorten that and narrow that window period so that more and more of those people can be picked up? It also reinforced the value of screening out people who were at risk for HIV.
Because most of these donors had risk factors?
Yeah, almost all the
all of them
donors
had
had risk factors, and so they could have been excluded, but they had donated, and they had donated during this window period, and therefore the transfusion, the blood was used for transfusion. It was interesting. We did that. I did that study from my desk at CDC. I did all the interviews by telephone. I wrote it up with the help of Scott Holmberg and Jim Allen and Harold Jaffe and others at CDC, and because of the national interest in this issue, the New England Journal, accepted it for publication, and so really helped define what else needs to be done to protect the blood supply. And I have to say, it really spawned this zero risk guiding principle of the FDA, that our goal is to make, the U.S. blood supply HIV free, and over the next decades, really, they have progressively sought to improve the antibody testing, sought to improve detection of the virus within that window period, first with a antigen test for HIV, and then by PCR, polymerase chain reaction, which is used today. And so that window period has become very, very narrow, and so it's very, very rare for HIV to be missed, certainly in blood banking.
Yeah, because back then, I think the ELISA tests, it took something like, I don't know, maybe about 8 weeks at least after infection to develop a level of antibody that was able to be detected by the ELISA test. And as you say now, the tests are such that they can detect evidence of infection within days of someone having been exposed. Did your interviews with these positive donors shed any light on why it was that high-risk donors continued to donate at blood drives? And did it help identify any additional measures that blood banks could take to try and dissuade donors from donating, or if they felt pressure to donate, other ways that it would be possible for them to alert the blood center that you really shouldn't use my blood here?
Yeah. I think it was a combination of donors not assessing their risk, fully. So they sort of
didn't really think it could
yeah,
happen
there
to
may
me.
be a little bit of self-denial going on, that I could really be at risk for HIV, AIDS at that point in time. I think that was part of it. The other part of it was how blood drives are conducted, where people did not feel like they could opt out without people feeling like, aha, he must have a
Because these are done like in the workplace
Yeah, in the
or in a church
workplace,
setting.
and it's a very
And if it's known
promotional
that-
expectation that you should be donating, and
Yep.
so people felt like, well, if I say no to the blood bank, people will think I'm gay.
Have a risk factor,
I have a
yeah.
risk factor, and so it helped people reevaluate how those blood drives were conducted, so that people had a better opportunity to opt out in a way that would be less stigmatizing for them.
I remember in those days, while we were working at CDC, there used to be, and there probably still are, I guess, the Red Cross would do collection drives here at CDC in one of the big auditoriums. And there would be emails that would go around, and my recall is that there was particularly a lot of pressure on people who had been previous donors to step up to the plate again. And so, as you say, in these kinds of settings, it would be potentially very uncomfortable for someone to suddenly say, oh no, I'm not going to do it this time. My recall is that I think some of the blood banks came up with novel ways to try and address this, to allow people to donate in a setting, but then there was, I think, another step where they had this confidential exclusion questionnaire where everybody was asked to indicate, should my blood be used for transfusion, yes or no, and people could say no, and it allowed them to donate, but then given this information that they provided in another question, if you will, to the blood collection agency.
The other thing that really changed because of the AIDS epidemic and the blood supply was how blood was used in clinical medicine.
Good point.
There was blood was heavily used in clinical medicine. I can recall during residency, it would be let's pink them up before they leave. Let's top off the tank.
Yeah,
And
right.
people would be given a couple of units of blood, just to sort of just as a final measure, and all that got reevaluated because of the AIDS epidemic and really trying to make a more judicious use of blood, and even capturing blood during surgery and having that used, and so it really the AIDS epidemic totally transformed the blood banking industry in this country. The other element of this is the plasma industry,
Oh, yes. Talk
and
about
that's where the clotting factor products were developed from plasma donations, and I'm sure Bruce Abbott and others you have interviewed will have talked at length about that, but that's quite a different donor pool that you're pooling from, much more frequent donations, paid donations, et cetera. And the products from those are, the products are manufactured from a large number of donations, and
That's
so
right.
your exposures through plasma products is much larger than through transfusion. And, regrettably, as you go around the world, HIV was introduced in a number of countries by the plasma products that were manufactured here
Such
in
as
the
the
United
clotting
States.
factor concentrates
Yeah.
that hemophiliacs received, your very first patient that
Absolutely.
you saw. His clotting factor concentrates were comprised of hundreds, if not thousands, of donors.
Exactly.
So a huge exposure over time, if you will. Your work in this area, actually, you were able to spin off, if you will, some additional studies in this area of trying to get a better handle on the risk related to transfusion-associated AIDS. Because now that you had a reliable test that could identify donors, you could, with obviously external collaborators in blood collection agencies and health departments and the like, get a better handle on just what the risk of transmission might be from an individual donor. And I'm thinking, if once a donor becomes infected, was it pretty much a given that he or she would continue, if they continue to donate, would have be transmitting HIV?
Yes, we did. Yes, we did studies looking at the whole donor history for repeat donors, and after a certain point in time, because of the way HIV persists in the body, that the donor remains infectious, certainly through blood transfusion and blood donations, leading to blood transfusions, for the as long as they donate. So you really need to get them out of the out of the donor circulation. You mentioned the natural history and how little was known in 1985. People knew, obviously, that AIDS could kill people, but you didn't really know, does it kill everyone? I mean, who survives this, who doesn't, and why? And so the natural history questions were really, really big. So my second project as an EIS officer was to develop the first natural history study of HIV at CDC, actually, and we did it by identifying these persons who had become infected through receiving contaminated blood. Now, the beauty of that type of cohort study is that you have a date of infection.
You knew exactly when they got infected.
You knew exactly when they got infected. The downside is that they tend to be older. They tend to have other diseases. They tend to die for the reason that they were given the transfusion to begin with. So you have some selection, issues that you have to be mindful of. And so someone getting infected at age 50 may not be representing someone who's getting infected sexually much earlier. But at a time when almost nothing was known about the longitudinal risk over time, it was a very important study. And we did that in New York, Los Angeles, and San Francisco. And I can this is when you were given orders without a lot of direction, but that sometimes works out. So the San Francisco part of the study was not going well. So Harold Jaffe said to me, "John, I want you to go to San Francisco, get the study straightened out. Don't come back until it's straightened out." So I spent about 2 weeks in San Francisco, which is not a bad place to spend 2 weeks, by the way. But also, it was the heartland of the AIDS epidemic in America. It was probably one of the highest prevalences. I can remember Jim Curran going there and coming back and saying, AIDS is palpable on the streets of San Francisco, and at that time it really was. I mean, you really could see people who were getting gradually decimated by their virus, and so it became a lot more in tune with what was going on, around the country. But we got the study going on. San Francisco became a very productive part of the study, and those researchers. Mike Bush and Herb Perkins and others did a great job, and Mike continues to be one of the world's experts on blood safety when it comes to HIV. But we followed them over time, periodic bleedings, periodic physical exams, history, and brought it together, and we found that about 50% of persons would die of AIDS within 8 years of their transfusion. So that was one of the first estimates of the natural history. What's your risk of AIDS and death after infection? And so that was also published in the New England Journal about 1989, I guess. So it was a very important information, at that time.
Were there any differences among the recipients in terms of their progression to AIDS?
Yeah, that was really interesting. So I found that if the donor developed AIDS soon after giving that unit, that the recipient progressed more quickly than recipients who got blood from donors who did not progress to AIDS as quickly themselves.
Who were still early in their own disease, so to speak.
Apparently earlier in their own disease. So that was also part of our findings. Now, what while we were doing those studies, and right around 1986, 87, as more resources, money became available, NIH became much more involved
Okay.
in HIV/AIDS, and so they funded a very large blood safety study. It's TSS, Transfusion Safety Study. That was a few years behind us, but was larger. And they found, and so that particular finding was not confirmed by their
Oh, really?
by their study.
Ah,
And so for whatever reason,
okay.
there may be other factors to explain that, sample size being one perhaps. That study was not confirmed. You know, we were reporting the data that we found. Not everything in science gets confirmed. It doesn't mean you did bad science necessarily. It just means you have differences in methodology or the population and other factors, and I think that was apparently the case for that particular finding.
Because I know in your paper you hypothesized that one of the possible explanations for this might have been related to what we now call viral load, that these donors who were donating close, sort of at the end stage of their disease, so they weren't they weren't symptomatic because they obviously would have been excluded as a donor, but that you were hypothesizing that maybe they had a higher viral load as their disease churned on, and that maybe these recipients were getting larger inoculums of virus. It sounded like a good hypothesis.
Right. At that point in time, we were just putting out some ideas for further exploration. That, or could you have more pathogenic strains of HIV that were circulating, and so we were just putting those out for areas for additional research. Yeah.
Now, you talked earlier on about your opportunities to be interviewing donors back in the study that you did with the Atlanta Region Red Cross. What about opportunities for contact with recipients? Were you interviewing those, or did you have contact with recipients or their families?
I did on occasion. In particular, I did a study at Cedars-Sinai Medical Center, which had given a lot of blood through their pediatric programs, particularly their pediatric intensive care units. And it provided an opportunity, again, to look at the natural history of HIV among children, which was even less studied at that point in time than adults. So we developed a study for that. It was the first time I met Dr. David Ho, who was a young researcher at Cedars-Sinai at that time, who later went on to become a science expert in HIV. And we would follow these children. And of course, this was a very particularly tragic set of circumstances when you have children who apparently has survived whatever disease resulted in them going into the intensive care unit, now coming out, and then several years later becoming ill and succumbing to HIV/AIDS. And so I had a fair amount of contact, with some of those families through the Cedars-Sinai transfusion service. And to show you how profound an impact this has, even 14, 15 years later, I would still get letters from the family members, the parents of those children, as they had taken on, as a cause. I'm sure sort of in memory of their children that they had lost, a real taken on as the cause, assuring that no one had to go through this again, assuring that blood banking was very safe, and looking for any kind of any weaknesses in the system, and so they would write me when they would see something in the media or something that they were working on, knowing that I had worked on this at that point in time, even though I had moved on, they had not moved on. And so, all around you at that point in time, or at least all around for me, you had those personal connections with the HIV/AIDS epidemic. And I'm sure that's still true for CDC and many of the large epidemics that we respond to. But, I mean, you're involved at a government policy level, you're involved at a science level, you're involved at a clinical level, you're involved with it at a personal level. And then I think the other telling part of the AIDS epidemic in the 80s was the community response. Just, being in the room with organizations that were developed just really out of pure desperation, a mixture of desperation and love. I mean, it was desperation because loved ones were being lost, and people who, weren't activists by training, certainly, but were becoming activists out of necessity. And the Lavender Hill Mob, ACT UP, we would have meetings like that at CDC with those organizations, being chaired by the deputy director of CDC. I'm sure it was a very new area for CDC to be involved in. And I think it was a real testament to CDC that to the flexibility of being responsive to a health crisis and then moving along and trying to engage the public in what you're doing so that you become to develop a team that works together rather than works at cross purposes. And I really learned how, whenever you can, seek to identify the community members who are very interested in what you're trying to prevent, and engage in them. Bring them into what you're doing. And maybe what you're doing isn't the best way. More often than not, working with those community-based organizations, I believe we learned something and benefited from it. They feel like, and then in turn, they feel like they're listened to. They feel like their government is a participatory government, not a top-down management government. And it really, it taught me a form of public health that I tried to continue to follow and to be respectful of the community-based organizations, be respectful of the public who's concerned about this, recognize that they either are living with it, have been impacted by it, and you can benefit from their point of view. And then by engaging them, they have a better opinion of what you're trying to do, and then more often than not will join forces with you rather than not. And having that, that energy is better than having people pulling in opposite directions, if you follow me.
Yeah, that's a really very good observation. And I think, I was going to say that AIDS, I think on a national level, international level, AIDS was probably the first disease that really brought about that kind of engagement. But I say that, but I'm also now, having listened to your stories of your early years in Alabama, that you actually, these electives that you did, that you went out into the community and lived with these Native American tribes in Alabama, you were actually doing that way back when, obviously on a smaller scale. But now, I mean, it's more or less become, I hate to say commonplace, but this idea of activism and on a national level, breast cancer awareness, AIDS awareness, all of that, it really got, I think, a big push from the AIDS epidemic. Now, not all of it was harmonious, because certainly in the early days, and we talked about at the time the serologic testing of the blood supply was about to begin, I'm not sure all of the activist groups were particularly happy about that. I'm thinking of gay men in particular.
Right.
That for them it was there were real concerns about confidentiality, concerns about the impact of a positive test on their livelihood and things of that nature. So I don't know whether you were directly involved or observed any of those discussions, but
Oh,
there
yeah.
there was not, at least in the beginning of
No.
testing of blood supply, complete agreement that this was going to be a good thing.
No, absolutely. I'm not saying it was all sweetness and light, but at the same time, we didn't shy away from the
Yeah,
engagement. You know,
that's a
you have
good
to sort of
point.
have to sort of stick with it, and I think even as you stick with it, even if there are differences of opinion, they. You have a higher likelihood of resolving them over time because you're working with them, and then as the AIDS community-based organizations became more established, right. I mean, some of their techniques were pretty astounding, with.
I'm-
So it wasn't all sweetness and light, but I
No.
think but as a young epidemiologist at CDC, learning that that should be an expected part of public health is to engage the community was not lost on me.
Well, I'm guessing that this is one of those lessons learned that you've carried on to your job in the Division of Viral Hepatitis. Because
Absolutely.
your time in the division as its director has been absolutely transformational in terms of some of the advances of therapy and vaccine and et cetera. And I assume that this is also a rubric that you're following in hepatitis in terms of getting community involvement.
Right. I think AIDS trained me well. I think my first supervisors, Jim Kern, Harold Jaffe, Scott Holmberg, Jim Allen, was part of that training, where you really were, where teamwork was valued, where people's opinions were valued, where you were expected to do a good job, and you were given assignments with that expectation. There was a real sense of expectation for innovation and new ideas, and not being stuck in the status quo, but that you were part of a large epidemic with a lot of unknowns, and you needed to try to step up and fill out that void so that we would have a better sense of how to move forward. So and then the community work and engaging partners that I've already mentioned. So I think that training has served me very well in my hepatitis work, where we now have a curative treatment for hepatitis C. A lot of issues regarding access and cost of treatment, stigma of people, marginalized populations having inequitable access to care. I have to say, what's missing in the hepatitis are those large, vocal, community-based organizations.
Really?
So I really miss them.
How interesting.
Yeah, and it's just because of the nature of the differences in the disease and the populations affected. So, but I really believe that my early years in AIDS has really shaped my whole career, in public health.
I wanted to ask you specifically about that in relationship to your tenure as the MMWR editor. Certainly, when you were a young recruit and junior epidemiologist, you certainly had your chance, I'm sure, to write many an MMWR article. And I was curious if your experiences working on AIDS influenced your thinking about the role of the MMWR during the public health emergencies that unfolded during your time as editor. I'm thinking specifically of the SARS, the worldwide SARS outbreak, monkeypox, which was an outbreak we experienced here in the United States. And I was just curious again about about how your early days on AIDS might have influenced your editorship at the MMWR.
Well, I became interested in the MMWR because of my work in AIDS. We would put out reports quite frequently to update the country and public health departments, of course, all around the country about what was changing in HIV/AIDS. So I became very accustomed to writing for the MMWR, and really began to value the role of policy development for CDC, how CDC can develop policies and put them out and really change the standards of healthcare delivery or public health delivery around the country. So I really began to be very appreciative of the role of the MMWR for CDC. And there would be some days because of the high visibility of HIV and AIDS where I would sit with Walt Dowdle and Jim Curran sweating over, one or two sentences in the discussion. And so that was not lost on me, the power of precision messaging, making sure that what you want to say is being said, is not being misunderstood. And that's very much what the MMWR really tries to do. So the editor did not turn over very quickly then. It turned over in 1998, and so I was ready for a change after 14 years of HIV/AIDS, and so I took that on. That sense of innovation, or the expectation for innovation that I picked up during my years at AIDS, was not lost on me at the MMWR, even though it was a fairly it's a publication that prided itself on not changing, but I felt like we changed it. So I invented the I invented EpiX, was this epidemic information exchange, a secure channel for people to share information about outbreaks that's still going on. We made it move out of just a weekly publication to one that could be published as needed, et cetera. So within a month after getting there, I wanted to start a continuing education program as part of the MMWR, thinking it would help drive interest and readership. That part of CDC had no money for that, so I called the AIDS program, and they had, it was the end of the year. They had some end of the year money, and so I was able to buy the 3 computer servers to help me set up the.
Really?
And it was the first online continuing education program at CDC was in the MMWR.
Didn't know
But
that.
but again, that was in part because of my relationships at AIDS. Then we began to have some major public health emergencies over my tenure. We had the anthrax
Of course, sure.
Cases right after 9/11 that we were heavily involved in. We would stay up many a night, working all night to get the report out by 9 a.m. the next day, as it was expected to be released at that point in time. I take it as a point of pride that at some point the FBI called the CDC saying that MMWR was releasing too much information. I thought that was I thought I was doing my job of information sharing for the public. So I don't put that on my resume, but I'm proud about that. And then we had a large outbreak that, Mary, you were involved in, SARS, coming out of China and Hong Kong, and. Mary did a great job of writing for the MMWR, as did a few others, and we really chronicled that whole outbreak. If you go back and look at the MMWR for SARS, every week you can see it unfolding and then seeing it sort of go.
That's a great word, chronicle, because for all the innovation that you and others initiated and the technological innovations that allowed CDC via the MMWR to do things like turn things around on a dime, not be restricted to a weekly format, be able to do it electronically instead of through the post, et cetera. I think it created a whole lot more pressures. I mean, the expectations were a lot higher. Be that as it may, in preparing to chat with you today, I had to look back at the first 5 years of the AIDS epidemic, and in those days, I don't know, I was told it was Jim Curran's idea, but all of the AIDS-related MMWRs were bound together in a series of volumes until I think the early to mid-90s. And I was actually astounded that in the first 5 years, beginning with that first June 1981 report of pneumocystis carinii pneumonia and Kaposi sarcoma among homosexual men, New York and California, CDC put out 88 MMWRs, and it absolutely chronicles in the unfolding of the epidemic in real time. And I think you're right. It did the same for anthrax, for SARS, and all of the many public health emergencies that certainly came after that. So it does serve as a timeless resource.
Absolutely, absolutely. And so I really, and that's why I wanted to be part of it, because I really saw it as a real gem for MMWR and for CDC, and people really, in fact, just to that point, during George Bush's administration, around 2003, 2004, we had some type of entourage come from the White House, maybe the Domestic Policy Council. So I was invited to the meeting. This is when Julie Gerberding was the director. And after the meeting, one of the people who was visiting pulled me aside and said, the MMWR is the one publication that we all read every week in the White House. So that was, we're a little off topic here talking about the MMWR, but just to your point, I mean, I don't know if the AIDS epidemic helped make the MMWR helped CDC, but I think the whole stature of the MMWR probably changed a little bit too because of that frequency of publication regarding HIV/AIDS in the 80s and the 90s, I believe.
Well, I think with the AIDS epidemic, and then, as you say, with anthrax and with SARS, people, and you've shed light on who some of the readership was and is, the FBI, the White House.
Right.
People come to rely on it as a solid publication that it's the facts. It's the facts and some interpretation and discussion, and it's reliable.
Maybe if I have time, one other point quickly, and maybe hopefully you'll be interviewing some of the people I worked with in surveillance, because obviously job one for public health and CDC is public health surveillance, and for AIDS that's determined by what's called the case definition, where it's what are the criteria that can you call someone to be AIDS. Now originally the first AIDS case definition was developed around 1982, early 1982.
Exactly.
And it was a constellation of diseases because you didn't know what was causing these diseases. And we had an AIDS-related complex of people that maybe was an earlier form of AIDS. But the point is, these diseases, which are rarely seen in people with normal immunity, would not develop, and there was a reflecting of their immunosuppressed status. Then when the HIV test became available, a few more diseases were added because the HIV test helped to identify other diseases that were associated with the infection. And so that was all very helpful. And then over time in the 80s, as CDC got more resources, we were able to give money to states to actually case count. And so the surveillance improved, which greatly helped our monitoring. So that was all good. So after my time in epidemiology and working on blood safety and a few other things, I got interested in surveillance. And so I went over and joined the surveillance program and eventually became the chief of the HIV/AIDS surveillance branch. And as a result, wrote a lot for the MMWR and a lot of other publications, and developed surveillance systems to look at various diseases associated with AIDS. You know, rightly or wrongly, some federal agencies began to use the AIDS surveillance case definition as qualifiers for various social services.
Right.
So, as a result, community-based organizations began to be very interested in the AIDS surveillance case definition because it would have an impact on whether somebody was getting housing or getting food,
Access to drugs or
Meals on Wheels, et cetera. So they began to lobby us to add certain diseases to the case definition. So we had to go through a very tough series of meetings to decide how we were going to change the case definition around 1993. And so we decided to add tuberculosis and to the case definition. And then there was a lot of interest in having cervical cancer because the immunosuppression increased the likelihood of a woman having cervical cancer, even though that was a very small number of cases relative to other diseases caused by HIV infection. But, speaking of very contentious community meetings, we had a very contentious one in 1993 that brought together a lot of groups in the CDC auditorium. And, we went through the process and got that case definition approved and got it written up and published in 1993, and it's still the surveillance case definition used today. So it's served the test for time. The other issue for community-based organizations at that time was HIV reporting.
Ah, yes.
Community-based organizations were a little more accepting of AIDS reporting because people often did not live long after that AIDS diagnosis. Their point of view, though, was that if you required reporting of an HIV test result, you may discourage people from getting tested because they didn't want their name reported to the government. And people were uncertain how the government would use that information, and particularly now that that person may live for a lot longer after that report. So it became a very contentious issue. It taught me a lot about engaging the community to get their point of view, to begin to develop working relationships with them. It also taught me a little bit about messaging what you're trying to do. I remember being on the phone with Jeff Levy, who was a major AIDS advocate at that time and helped develop the Ryan White legislation and has gone on to a public health career of his own. But at that time, he was the AIDS activist and I was the surveillance program representative. And I remember being on the phone with him one day and him saying, why does the government need my name? Why does the government need my name? And I say, well,
and it's not the federal government. Because
it's the state government, right?
The state government.
CDC
The federal
does not
government had
get it.
long ago not
Right.
been
CDC
taking it. So
does
we're
not
talking
get
about
it, but they
local.
tend not to make that distinction. But
That's true.
But why does the government need my name? And then I start saying, well, it's because we want to ensure the quality of the data and this kind of stuff. He goes, stop right there. He goes, my soundbite is better than your soundbite. He goes, so I win. Now, you could be cynical about that, or you could take that as a lesson. And that lesson was he was right. It was a compelling message. Like, if you can't adequately explain your point of view succinctly and in plain English, then you need to go back to work until you can, or maybe your position's not that strong to begin with. I mean, the point was, maybe they did have some legitimate discrimination issues. Maybe they did have some stigma issues. Does it really? And maybe our pursuit of data quality doesn't really match to that risk. So the risk-benefit calculation was not good. Now, since that time, more and more states adopted HIV reporting. Okay. Of course, I think all states now require reporting. But we have new treatments now. There's not it's a whole different environment. Also, more of that information now is used to actually help people. Data to care, it's called. So rather than just using that information for pristine epi information, it's actually being used to benefit individuals, and so that changes that risk-benefit calculation. So again, I think that experience in surveillance, was, just very instructive of how to get things done in public health.
Well, I absolutely agree, and we have in this oral history been fortunate enough to capture in detailed interviews from people that have been very involved in surveillance, like Richard Selleck and Martha Rogers, who was involved early on in pediatric surveillance, and Tim Dondero. And absolutely, agree with you, it's the bedrock of everything that we do. I mean, going back to your early days in transfusion aids, there had to be a starting point, and it had to be the ability to access information about cases. There had to be a mechanism to get cases identified and then reported in a systematic, cohesive way to serve then as the basis for learning much more through detailed epidemiologic studies that you and others did. This has just been very interesting, talking about your work on AIDS from very early days, and certainly the hepatitis epidemic, which is another whole interview.
Yeah,
I think we're going to have to do
right.
oral history on hepatitis.
I hope so.
Before we close, is there anything about your work related to AIDS that we haven't discussed that you'd like to specifically note or comment on?
Well, I felt very just fortunate and privileged to be part of CDC at that point in time. I really, it was my introduction to public health. At that point in time, the attitude around being an EIS officer was that they wanted people that didn't know much about epidemiology or public health. They wanted a clean slate so that you could be taught the CDC way of public health. So I was a very novice coming in, and people were very good mentors. But they gave you responsibility at the same time, and as I mentioned before, they really appreciated CDC at that point in time in that program, really encouraging you to speak up and really valuing
Yes.
opinions around the table. And I think you really create that atmosphere. You can more often than not get the best out of people because people feel valued and respected. And I think that together with a sense of innovation and seeking to do the right thing, keeping your eye on the health outcomes you're trying to achieve, and really being developing warm collegial relationships all along the way. I think it's really been like I say, a great privilege to be part of that, and so I was glad I got a chance to talk about it today.
Well, John, thank you so much for your time, and this seems like a good place to close on this note, and thank you again.
Thank you very much. Appreciate it.